I'm going to go ahead and put our recording on as we wait for Dr. Gupta to arrive. We're expecting a large crowd today on the long-term effects and acute effects of COVID-19. So, as you know, this is a public and free conversation that will be recorded. So if you do not want to be part of the recording, go ahead and turn off your video, and everyone please stay on mute. We do expect Dr. Gupta momentarily, but in the meantime,
I think you should be now.
in the meantime, I want to go ahead and turn it over to Dr. Dale Reisner, who will start us off with just kind of a brief overview and some good news for a change on what's happening with the COVID-19 numbers. Dale?
So hi, everyone. If you haven't met me before, I'm a board member of Health Advocate X, and I'm the medical director for OB/GYN quality and safety in the Swedish health system, and have taken a specific interest in trying to stay totally up to date with where we're going with COVID beyond my everyday life. So I usually start with talking about the data that's global, US, and then we do a drill down into Washington since that's where we emanate from. And always, if you're interested in your own state and you're here from another state, please access your state information, typically through the state initials .gov. Department of Health or DSHS. One of those two usually gets you exactly what you would need for your state data. So the data I'm presenting today is from the CDC as of yesterday. If we look at the global case rate for confirmed coronavirus 19, over 106 million people in the world have had confirmed cases. We know it's more than that because the testing hasn't been universally available. And of those, 2.3 million people have died across the world. In the United States, again, as of yesterday, over 27 million confirmed cases and 467,000 plus deaths. So we know that there are still several states in the country that are particularly high and still having increasing cases. Those would be California, Texas, Florida, and New York. And in Washington state, we've had some decreased trends. And if you look across the country overall, there are decreased trends. But I do want to couch this with that there are reports of some of the variants, and we can talk about this. We're actually going to focus a lot on this at next month's talk, but the variants, because they seem to be a little more infectious, are on the increase in a number of states. And these are from a bunch of different sites. And we can, if there's a little time at the end, talk a little bit about how vaccination can potentially be affected by all of this. But the other thing I just wanted to say is that the highest peak, if you look across the world and across our country, was on January 7th. Kind of that week after, week or two after Christmas and New Year's and other, international holidays. And it has been trending down since. We just don't know if we'll have some other little bumps along the way. So
that's great. So
I'm going to end with that. Yes.
Thank you so much, Dale.
Yeah.
And we're so grateful that you can always steer us with the overall numbers. And now we're delighted to welcome Dr. Vin Gupta, who is assistant professor at Institute for Health Metrics and Evaluation. And he's going to give us an orientation to understanding the clinical characteristics of long-term COVID-19 syndrome, understand the potential medical needs for this patient population, and discuss the importance of vaccination, especially talking with the public. And we're so fortunate that he's so generous with his time. We have about until 55 of the hour of his time. So I would ask that if people have questions, just throw them in the chat and we will continue our conversation. And with that, Dr. Gupta, welcome.
Thanks so much, Robin. It's great to be here. And thanks for the invitation. I'm happy to just start out talking about some of the issues you just identified, and then would love to get into more of a dialogue, and if folks have questions, to do my best to answer them. What I'll say is, starting out with long COVID syndrome, this is something I get asked about a lot. I get calls from friends, family, from people who've gotten to know me, and universally, one of the questions I get is, well, hey doc, I felt great. I was otherwise healthy. I didn't even need to go into the hospital. I had mild COVID. I was just isolating at home. And it turns out that now I'm still fatigued. I'm sleeping 8 to 10 hours a day, sometimes even during the daytime. So daytime sleepiness fatigue. We're using the term brain fog because they're feeling sometimes confused even. And there's been this analogizing of long COVID, some of these symptoms of fatigue and confusion, to chronic fatigue syndrome, or to even chronic Lyme disease for those on this call who might have some familiarity with that. This notion that some sort of infection, whether it's from Lyme disease or from now COVID-19, can cause these really non-specific, really frustrating chronic symptoms. And is it a manifestation of chronic infection, or is this actually still the virus wreaking havoc? Is it persistent inflammation as a result of the acute phase of illness, and it's just not going away? What is it? We just don't understand it well in terms of what's actually happening in the body. And frankly, we don't understand chronic Lyme disease or chronic fatigue syndrome all that well either. These are just really debilitating illnesses though. And so that's the top line here. Long COVID, there's more we don't know than what we actually know. And I will say, as a clinician that gets asked questions, that's trying to help patients through this really difficult post-acute phase set of or constellation of symptoms, that because we don't actually have a standardized definition of, well, if you meet a certain set of criteria, or 3 out of 6 set of criteria, that's generally how we diagnose a syndrome. Because we don't actually have that for this condition, there's a lot of impacts to that. Number one, as we all know on this call, our health system, and I don't mean to open up a can of worms here, but our health system operates by profit. And if there is not a reimbursement mechanism for the provision of care for a syndrome or a problem, then that causes a big void in what types of services are actually offered to patients with this syndrome. And the reason I bring that up is because there is no set criteria for this syndrome, because we're learning as we're going, because we don't really know what the symptom profiles are of people with long COVID. I mean, of course there's brain fog, of course there's fatigue. It looks like studies out of Italy and out of the UK suggest that at 3 months after a hospitalization, there's persistent cough, shortness of breath potentially, in addition to some of these other symptoms I mentioned. But because there is no rigorous set of criteria, there is no code. There's no billing code that the Centers for Medicare and Medicaid have identified as representing this constellation of symptoms. And what does that mean? That means that people out there who need help, who need post-COVID care help, don't have an infrastructure set up in parallel that can actually help them at scale. Because unfortunately, like I said earlier, everything in our healthcare system operates ultimately by what's happening at the bottom line. And so we really, and I'm not endorsing that. If anything, I'm trying to give a nuanced critique of it, which is to say that's wrong. And what we do need is we need studies, and we need more patient registries to really drill down what are the criteria here that define this syndrome, number one, and then number two, actually set in place a system in which we can provide care. It can be reimbursed. We can improve that level of care, so we can actually get people the care that they need. Post-COVID care, I'll pivot in a second to vaccines. I'll
Can
say
I ask you a
post-COVID.
quick question though,
Sure.
which I think is an obvious one for advocates, which is what will there be certain institutions that will be studying this, and have they already started? Is there a way to get our, the clients and patients that we know have experienced COVID into these registries, and how can health advocates help?
So thank you, Robin, for asking that. I would encourage all of you. I'm a medical advisor for one of the biggest advocate groups for long COVID, and it's survivorcorps.org, I believe. Survivor. If everybody on this call were to go to Survivor Corps, and I will, I'll try to Google the website here actually in real time, if you don't mind. I know this is the virtual world we live in. It is. I'll find it and I'll email it to you. But it's Survivor Corps, and what you'll find here. Let me see if I can actually find it here in real time.
Somebody just posted it actually. So
perfect.
Doka just posted it. Thanks, Io.
Survivorcorps.com. That is an excellent example of what's happening in real time, Robin. There is no centralized NIH-driven process to speak of at the moment, but Survivor Corps is a community of individuals that got together and have brought awareness to this condition. They've forced, actually, through meetings with Dr. Fauci and then NIAID, NIH, to say, listen, we need registries, we need studies, because we need an infrastructure in place right now to care for these patients over the long term, because this is going to be a big issue moving forward post-pandemic, providing care for these patients. This is a syndrome that we have no idea how long it will last. We know that these patients potentially will need a set of rehabilitative services that focus on psychological, mental health well-being, because people feel extremely debilitated. I often hear, hey doc, nobody believes me that I'm having this syndrome because none of the tests that have been run on me are abnormal. So the psychological impacts of COVID-19 or long COVID are enormous, because nobody can point to a reason why people are feeling this way. So that's really difficult. Of course, physical pulmonary rehabilitation, if people are feeling weak or short of breath, is going to be vital. And I'll say, Robin, that the big issue here that this syndrome and this pandemic ultimately is drawing attention to is the fundamental inability of our healthcare system to provide at scale post-hospital, potentially even in-home rehabilitative services. This is irrespective of the pandemic, but this is certainly relevant to the pandemic, and these patients in particular. We're not great at that. We just don't have. There's a huge dysynchrony between supply and demand. There's a lot of demand for this specific type of services or set of services, but we don't have enough people trained to provide them. And again, the incentives to have people go into these career fields and to make sure that they're protected, that they have adequate workplace health and safety provisions in place. There's a whole void there. And I mean, hopefully we can have a larger discussion about this as a country.
Yeah, and I think there are a lot of questions coming in, so I'm going to field some of those for you. But I'm kind of curious. Ordinary primary care physicians are probably, ill-equipped to answer, what we don't know about this virus. So, as advocates, how can we prepare our patients to ask the right questions and navigate care appropriately?
Absolutely. So I think I would say for all the advocates on the call, if you know somebody, I'm just looking at the questions myself. If you know somebody who has had that has had COVID, that is experiencing any of the symptoms that were mentioned, what I would recommend you do is have them, if they haven't already, make an appointment with their primary care provider. Because one of the key things that I would suggest, if I were seeing a patient, for example, let's say they had, they're a few months out, they're feeling really fatigued or they're short of breath. Those are the common symptoms that we're seeing. As a pulmonologist, I would treat that individual the way I would treat any individual who has chronic lung disease, at least I would say to myself, you know what? I want to make sure that we're not just consigning you to a syndrome and throwing our shrugging our shoulders and saying, well, you know what? Not much we can do. It's just hopefully it will go away with time, but we just don't know enough about this syndrome. No, that's wrong. And I know somebody mentioned Diana Barron, who I work closely with on Survivor Corp. We strongly believe all these patients, and this cohort's going to grow in the coming months and potentially even the coming years. They deserve, and unfortunately, let me qualify this even further. A lot of these individuals don't have access to healthcare because these are individuals, again, disproportionately the people most affected by this pandemic are the ones who are least likely to actually have the services they need. But if I had somebody who told me that they were having these symptoms, I would want to make sure they had pulmonary function tests. I would want to make sure maybe they even got an echocardiogram to see if long COVID, we know long COVID can cause inflammation of the muscles of your heart. And there's potentially that could be treated, not just through time and hoping for the best outcome, but we could actually treat that. I would, even so chest imaging, pulmonary function tests, and echocardiogram are some of the basic tests in addition to some lab work that I believe should be done. So we don't miss something that is potentially reversible. And I'll also add, actually just over the weekend, I got a call from a newly hired correspondent for NBC. This is a gentleman who is in his early 30s, otherwise healthy. Spent 2 weeks, high fevers at home with COVID-19, but was still okay enough to stay at home and isolate. And now is basically sleeping all day, has brain fog, touches his head, has pain wherever he touches his skull. All his tests thus far have been negative, but he's meeting with his GP today, and I pushed him to make sure that he gets a neurology referral, because we know if you're younger and you have, he has new onset migraines, for example, never had migraines before. That's unusual. And to say, well, that's a long COVID, see me in 4 months, that's wrong. And so I actually told him to take a daily aspirin, full dose, and presume for right now that maybe is he one of these young individuals that might have had a blood clot and we just don't know and it was minor enough. So let's get a non-contrast head CT and get him in to see a neurologist. It's better. I'm somebody who believes in quality of care, not quantity of care, and that everybody deserves durable access to healthcare. This is one of those cases where I think making sure that long COVID is a diagnosis of exclusion, and that we haven't missed anything, is vital. So if you're hearing me say, well, Dr. Gupta is saying get 6 tests, I'm not somebody who wants to get a bunch of fancy tests normally, but in this case, because COVID-19 wreaks havoc on vital organs, I think it's better to be cautious and vigilant and get some of these studies. So that's what I would say to all of you. If you know somebody who's suffering from brain fog, confusion, fatigue, shortness of breath, weeks to months out from their acute phase, push them to see their provider. Hopefully they have healthcare and have that access, and then push them, if that provider is not being aggressive enough, push them to advocate that they need those services in an abundance of caution, because there's certain things we can treat.
Should everybody have on hand a pulmonologist? Do you think that everybody who's had long haul symptoms should have a pulmonologist at hand?
I think it depends. If the symptoms of long COVID are fatigue or shortness of breath, then yes. If they're brain fog or migraine headaches, or that spectrum of illness, but not necessarily impeding one's ability to move around or to walk up a set of stairs, then perhaps not. I do think pulmonologists can offer access to pulmonary rehab, and which is often gated. You often have to see a pulmonologist before you can actually get clearance. I'm sure all of us are familiar with just the fact that certain things you have to get referrals for. And so I personally, you're going to see in the course, it's already happening, multidisciplinary post-COVID care clinics across the country that will have infectious disease experts, behavioral health specialists, pulmonologists, primary care physicians, and other providers working together multidisciplinary to provide support for these patients. But again, that's going to take time.
Mhm.
In the interim, I would say see a pulmonologist if you're having difficulties with your activities of daily living.
Mhm. Thank you for that. And lots of different questions here. Do you know if there are any MRI studies in aggregate that are showing how COVID affects the brain long term?
I know that, nothing that has been rigorously peer reviewed, I think in a high quality journal quite yet.
Mhm.
Having said that, but that data is being accrued in real time. I will say, and for those who know Survivor Corps, Diana recently has been sharing basically pictures of the lungs vasculature, so the arteries and veins in one's lungs, pictures in what are otherwise healthy lungs, and then the post-COVID lung. Excuse me. And what I would say is, it's dramatic. Of course, I know this is. She took a particular. She took a picture of. We can get fancy CT scans that can just look at the blood vessels in the lungs, and really what we saw, in an image that she shared, which I'll try to find an email to you, Robin, if you can circulate,
Sure.
is a dramatic decline in the number of functioning blood vessels in the post-COVID lung, meaning we know that COVID-19 causes the body to tend to clot or increases the tendency of blood clots in the body. But we often think about these big blood clots in your leg, or maybe in your, a big one in your lung causing a pulmonary embolism. These are little, what we call microvasculature or microthrombi. So really tiny clots scattered throughout multiple blood vessels in your lungs, ultimately causing shortness of breath. If you have a lot of tiny blood clots in every blood vessel in your body or in your lungs, that is ultimately going to impact the ability of oxygen to go from the air sacs, the balloons in your lungs that you breathe, that oxygen you breathe in, for that to go from those air sacs into the blood vessels surrounding the air sacs. All those blood vessels in this picture she shared had blood clots in them. And is that representative of every single lung that has seen COVID-19? No, but it shows you the degree to which COVID-19 can cause pneumonia, so fill the lung sacs with pus, or the degree to which COVID-19 can cause the blood vessels around those lung sacs to get clotted off with blood clots. So it exacts a lot of different pathologies just on one vital organ.
And is there anything in general to kind of this new language of prehabbing? So basically being preventative after you've had COVID-19 that could potentially positively impact the potential for what you're talking about.
If somebody on this call can give me the answer to that question, that's a great question. I'll readily tell you what I don't know, and the answer is I don't know. It would make sense to me to always, obviously, keep your cardiac output as high as possible. And so if you're at home isolating with mild to moderate symptoms of COVID-19, but if you can bring yourself to get out and still have a walk masked, by all means. So I think that would actually improve your, here's what I would say. If you're healthy enough to do that, I think the risk of you then ultimately developing significant long haul COVID symptoms is probably lower. And so part of it is selection bias. If you're healthy enough to prehab, you're probably, is it the prehab that's actually preventing bad illness, or is it the fact that you're healthy enough to do prehabbing that suggests that, well, your lack of severe symptoms is actually the reason why you're not progressing with long COVID?
Here's a question from Michael Wood. A friend got COVID twice, still has fatigue after 3 months. Should she and others like her get the COVID vaccine?
Absolutely. And so there are and I say this as somebody who's been vaccinating both in a few of the roles I have, but we just did a big rollout of vaccines down at Lewis McCord this weekend. And I would say, so become intimately familiar with the contraindications. The only contraindication to the COVID-19 vaccine, absolute contraindication, meaning do not get the vaccine, is if you received the first dose of Pfizer or Moderna's vaccine and you had an anaphylactic severe allergic reaction on the spot, or in that first 30 minutes after, or 15 to 30 minutes that we're watching you, then you should absolutely not get the second dose. Mm-hmm. So that is the only absolute contraindication. There's a few relative contraindications. One of which is if you have been infected with the virus and yet still continue to be symptomatic in the acute phase. So meaning you're within, say, the first 2 weeks of your illness from the point of diagnosis, from the onset of symptoms. That's when we would say, let the acute symptoms resolve. If at 3 months somebody has persistent shortness of breath, but their diagnosis was 3 months ago, we don't think that of course they have persistent symptoms, but the big issue there is not the symptoms. It's what we don't want is the body's fighting off in the acute phase the virus. It's developing its own immune mechanisms. We don't want that to interfere with its recognition of the vaccine and its ability to produce antibodies to the vaccine. So that's why we say acute phase symptoms, wait for them to resolve or at least to attenuate, and then get the vaccine. I know it's a little confusing because if you're like, well, hey doc, I'm still symptomatic 3 months out, what's the time point in which we're good with the vaccine? I would say as a rule of thumb, if you've had, there must be, hopefully there's a transition from the acute to chronic phase. So usually that means at least resolution of fever, even if you haven't totally resolved your shortness of breath or your cough. If somebody is persistently short of breath and still coughing, at least look for when their fever has resolved as the point in which you can say, all right, maybe you're transitioning from acute to chronic phase. I don't know if that's clear for everybody, but I want to make sure that distinction, because this can be confusing. Somebody who goes immediately from acute to chronic never fully resolves and feels normal. When do you know when it's okay to get the vaccine? I would say once your fever, if that was present, resolves, or once your shortness of breath has improved somewhat, even if you're still symptomatic. Improvement to me is the sign in which you can say, all right, my body has gotten used to the virus, I can get the vaccine. But everybody should get the vaccine irrespective of prior infection history.
Okay, that's helpful. Thank you. We also have this question from Elizabeth Schuler talking about primary care lab tests. So which ones would be a starting point to check on long-term fatigue and muscle aches?
So I would say if I was evaluating somebody, I would want to get a basic complete blood count, so a CBC. I don't know how granular everybody wants me to get, but I'll just go for the full details. I would say a CBC. I would want to check a thyroid level because, again, you want to be holistic and not assume anything. And we're learning about COVID and its impacts on every vital organ in the body. So a complete blood count, what we call a TSH, which is a thyroid stimulating hormone. It gives us a sense of how your thyroid's functioning. Who knows? Maybe you might have either picked up a new thyroid condition, or you might have had it previously. But if somebody comes in with this sort of constellation of fatigue and aches, I would want to be holistic. I would want to check muscle enzymes and markers of inflammation. So something called a CRP and something called an ESR. These are markers of inflammation. Is your body still fighting off inflammation? I would also want to check something called it's called a CK, a creatinine kinase level, CK. And that tells you if your muscles might be really inflamed at the moment. So that could also be helpful. You could consider checking an adrenal level, adrenal hormone level. Again, some similar mindset to why one would want to check a thyroid level. If somebody comes in with fatigue and it's a sort of a chronic fatigue syndrome, you want to make sure you don't actually have a low hormone level, because they can mimic each other. So again, holistic. And then I would start there. And I would also lastly check a D dimer, which would, if elevated, potentially suggest you have a blood clot. It's very imperfect screening tool for blood clots, but it's potentially elevated and might help signal, okay, maybe we should get some advanced imaging tests in the event that that's positive. So those are some of the lab tests I would get. And then again, if any of those are positive, or frankly, if all of them are negative, but people are still feeling short of breath or fatigued, I would move to the potentially considering an echocardiogram, some sort of chest imaging, and pulmonary function tests in an effort to really understand, is there something reversible here, or is there an explanation? And if there is none, and there potentially could not be, then at least we know supportive care is truly the only option right now. But who knows? Perhaps a course of steroids if there's signs of inflammation around the heart muscle. There's been indications, and I've seen case studies of using long-term steroids in our long-term COVID patients who have persistent shortness of breath. So there's a lot here that you could potentially consider doing, but it's important to be holistic and to not be rooted in thinking, as at least from the clinician side.
Well, and it sounds like at the moment, it's just unclear how to treat. Beth, did you want to jump in?
Yeah, I just, Dr. Gupta, I wanted to ask, because you're at the UW and we have a lot of Washington State advocates, not all, but I'm just curious for the long-term patients and friends and family that we're getting all these questions from. Is there someplace, a multidisciplinary post-COVID clinic at the UW or being developed at the UW to refer them to besides the primary with the other referrals?
You know, I am glad you asked that question, because I looked into this. The short answer is it's not nearly sufficient enough, but I am going to, it is actually, oh, here we go, perfect. I am gonna drop the link in here.
Okay.
There is one telehealth clinic that you can find here at this website. We've been working to, and it's the good work of Diana's team at Survivor Corps, but this is the one specifically in Washington State. And it's led by a rehab medicine specialist. It's a telehealth based service right now, at least. And what they do is, as I understand it, they do intake. You don't need a referral for it. There's the number and all the information. It looks like Swedish is starting a clinic as well, per Rosemary, which is great. But what you're going to see, and I think in Idaho, actually, for those that are in Washington State, maybe on the eastern side of Washington, I'm not sure if you can potentially access care in Idaho, but I saw that there's 3 different clinics in Idaho, all of whom use a multidisciplinary approach, multiple different specialties as outlined. And I think, you know, to answer your question, Beth, it's not going to, I don't think we know what types of support services will be needed. So that's why you're seeing infectious disease specialists, lung docs like me, occupational and physical therapists, and, you know, some sort of mental health support, all bring to bear into these clinics to some degree. But you know, there's a lot of work to be done to staff these appropriately, and it's just not there quite yet. But hopefully that's helpful.
Thank you.
And here's a question
from. I'm
from.
sending all my messages to Robin. Whoops.
Oh, okay. Well, I'll make sure that they get sent out to everyone. Not to worry. Here's a message from Eva Fletcher, who says that she knows that healthcare providers working in a hospital, some of who have had COVID early on and still have antibodies, are delaying their vaccine in order to let other people go in front of them. Is this a good idea? Should they get vaccinated despite positive antibodies? That's a good question.
I guess my advice would be get the vaccine when you're first eligible. And I've heard a lot about giving up your line to others, and I think that's noble. And but I would say in this space, don't assume anything about your level of immunity because you've had the illness previously. It dramatically varies, and the CDC, to this day, frankly, the CDC still has, I think, ultimately sometimes really dissonant guidance, and I can get into that in a second. But when on this specifically, there's a sense here that, oh well, for 90 days potentially you're protected from reinfection to the virus if you've been naturally exposed to it, and that's just wrong in my opinion to continue to put that out there, because now we're seeing that natural infection does not in any way connote immunity to, say, the infection from the new variants. And now here we are super worried about the new variants. And so why they're not keeping up with that guidance, I don't know. But that is yet another reason why I would say once you're eligible, if you have a slot, take it, because this pandemic continues to change day over day. And I don't like that guidance. Again, if you're over the acute phase of your symptoms, then you should get the vaccine. And I really believe in that, especially with all the unknowns that continue to be injected into this scenario.
So there is some concern about the safety of vaccines in general, and we'll talk a little bit more about that next month with Larry Corey, but this is a specific question about people waiting for a safe vaccine. And do you know of any integrative functional medicine physicians or centers that have a different point of view on the vaccines and what's safe or not?
I don't know the integrative functional medicine piece, just to be candid. So I'm not best positioned to answer that. What I can say is, and this is what I've tried to message to folks that ask me, because I think this has gotten lost, and I'm going to try to put this into the chat. It's a very interesting way to have panels. It's going to be hard to go into real panels in the future.
I know.
Can't be Googling in real time. Here, I'm going to put this in. This is what I'll say about this. This is generally my response. Are these vaccines 100% safe? I would say they're darn near close to that, in the sense that, are you going to feel injection site soreness? And are you, especially, are you going to, I'll say after the second dose of the Pfizer vaccine, I went to bed early. I had some chills that night. I felt achy and I felt great basically 24 hours later. So was there some temporary inconvenience? Yes. Are there cases where people have had anaphylactic reactions? Almost negligible, but yes, there are the few that have gotten outsized media attention, and it's kind of spun up this whole thing. These vaccines are super safe, and there's a lot of conspiracy theorists out there that give me headaches on social media, suggesting a link between the vaccines and myocarditis and all that. That is just complete nonsense. And there's no proof in any of the clinical trials that these vaccines cause anything but the rare allergic side effect that's readily treatable. But then when I say, and I would say this to all of you as health advocates, because I think it's really vital to get this message out to people who are understandably hesitant or are skeptical about the scientific process, either because of historical reasons or because of our politics, that these vaccines, Johnson & Johnson, AstraZeneca, Pfizer, Moderna, you name it, will keep you out of the hospital and from seeing me in an intensive care setting. That is 100% true. And does that mean every vaccine will protect against sniffles or that you might have some body aches? Those all might be true, but it's also true that, and I put the image of the CT scan in the case that I've been trying to message on. I think people have lost, I'm not saying anybody on this call, but because we cite numbers and percentage effectiveness and one is better than the other, when I'm vaccinating people here in Seattle or Lewis McCord, they're asking me, well, hey doc, I want the Pfizer vaccine, not the Johnson & Johnson one, because one is better than the other. And the truth there is that both are equally basically the same performance when it comes to keeping you out of the ICU and saving your life. And I think we've lost sight of that as a public health and from a public health comm standpoint.
That's great and a good reminder. So thank you for stating that so clearly. That's really great. There was a comment in the chat, a couple things. One was the telemedicine clinic that you mentioned. I don't see it in my chat, and I don't know if you can get it to me later, but that would be great to share with people. Okay. Oh,
right
Rosemary
now.
Grant just linked it. Okay, thank you. I think somebody took care of that. And there was also a comment about, I know there was some research on vitamin D helping with prehab in COVID. Do you have anything to share about vitamin D? Should people be taking it as a supplement?
I've seen some studies suggesting, I've had individuals, thanks, Rosemary. I've had, perfect. And if you actually go to the website, gosh, here, before I forget, you can actually get the numbers. Sorry. Here we go. The actual number is here, or it might be at the site. Also at the site where Rosemary pinged to. Hopefully that's going to everybody.
Yeah, thank you.
And then if you go to that website, and if you are in Eastern Washington and can access services across state lines, I know that can be tricky. There's 3 similar clinics that seem excellent in Idaho. The vitamin D piece, I don't feel like there is such strong, overwhelming data in early COVID. So some of the evidence I've seen suggests that if you take vitamin D at home, if you've been diagnosed with COVID but have early sort of mild to moderate symptoms, that it could potentially be helpful in staving off progression, and certainly maybe even in averting long COVID syndrome symptoms. I don't think it's going to harm you. I think the data certainly is unsettled to the point that there's certainly no societal recommendations or sort of like broader recommendations saying, yes, definitely take vitamin D. So it's one of those areas where I'm not going to push back on it because it's not going to harm you, like hydroxychloroquine.
Mm-hmm.
But it's also, I would caution to people that it's not a panacea, and it remains, I think, inadequately studied for the specific use of preventing progression of the virus if you have early mild symptoms.
Mm-hmm. So another question here. My aunt has been in the ICU for 3 weeks, COVID-based embolism to her large intestine. We seem to be focused a lot on death numbers and the long haulers, but not on the devastation that the disease can cause. If she survives, she'll be on TPN permanently, and it's an extremely dangerous disease. So I have a question. In the 1980s, I was involved in the America Responds to AIDS campaign that the government put on, which was just really clear message to the public. Do you think there can be some kind of government public education campaign to kind of pull all these messages, information together to help the country understand this disease and also learn from what we're finding in real time?
I hope so. I will say, as somebody who's been trying to use a small platform to do just that, that it's hard to do it when you're counter messaging the government, or if anything, even now, I will say that I'm a little astonished that in one breath we can tell people to double mask and to minimize your time in a grocery store to say once a week for 15 minutes. And to avoid Super Bowl gatherings or what have you, but we're still saying it's okay to go to indoor dining with restrictions. We're still saying it's somehow okay to be in poorly ventilated classrooms. I don't even want to start that debate here because we all want those things, of course, but it's dissonant to people and it's confusing because the two don't necessarily align. And it kind of feels like we're cherry picking data and evidence to suit the reality that we want. And so I think consistency is important, even if it means unpleasant realities in the short term.
Mm-hmm.
and we have a vaccine here. So, I mean, this could all be temporary, and in the midst of consistency would allow decreased transmission and mitigation of loss of life. I mean, we're already at nearly 500,000 lost. So at this point, it's already, no matter, there's no good way to look at this, at what we've endured here. Is just trying to mitigate now. But yeah, I think I'm actually a little surprised. I'm very surprised, and this is going to change in the weeks ahead, but a clear messaging campaign around the vaccine. I mean, I think this country is filled with amazing marketers. And yet I feel like this whole effort around messaging on the vaccine has been completely confusing and has forced people to literally the feedback I get is, I want one vaccine, not another vaccine. And that to me is a failure of marketing and of the lack of a think big vision around how we should be messaging on this, which is, you get this shot, it will save your life and the life of your loved ones. And the quicker you get it, the quicker we can plan vacations and normalize life. I mean, to me, the message here is simple. And yet we're talking about anaphylactic reactions and 75% versus 92%. It's just, I think we could do a lot more.
And perhaps that is a nice opportunity for an organization like Health Advocate X to work with health advocates and patients to make the messaging very, very clear, to get out to everyone. So thank you very much. I know that I have some messages from Dr. Steve Overman, who's a rheumatologist here, and he wants you to comment on, I don't even know what this means, baby ASA for antiplatelet effects given the general coagulopathy.
Yep.
I don't know.
No, I think I have I know where the doc is going.
Baby aspirin.
It's one of those things where, so I think, and by all means, correct me if I'm wrong, but I think the question basically is asking, if you have COVID-19, and please correct me if I'm not capturing the spirit of the question, but because we know COVID-19 causes blood clots potentially could cause blood clots in parts of our body, and say you're home and you're not sick enough to go into the hospital, but you're home isolating, should you take a blood thinner like a baby aspirin every day to mitigate the risk of developing a clot? If you're in that sort of cohort where you have COVID, but you have mild symptoms, I say, why not? That question specifically has not been asked or answered, I think, with strong data. But the truth here is, if you required oxygen, you would be in a hospital and we'd be giving you the equivalent. We would be giving you heparin, as the doc knows, 3 times a day, probably. And so, why not do something similar, especially if you're going to be predominantly sitting around, maybe lying around in bed? Yeah, I think take the baby aspirin, absolutely. And I will actually say, this brings me back to long COVID. I had an individual, my colleague at NBC, on the NBC side, asked me how to manage his brain fog. And in addition to pushing him to get a neurology assessment and a CT scan, just to make sure we're not missing anything, I advised him to take a full dose aspirin until we got confirmation that he didn't have anything like, say, a blood clot. Because I've cared for many young individuals who've had blood clots, strokes, that may have gone undiagnosed. And so it's better to know. And I would say, unless you have, say, peptic ulcer disease, unless you have a bleeding disorder at baseline, you're a hemophiliac, or you're on another blood thinner, unless there's a reason why you shouldn't be taking a baby aspirin. So usually that's if you have really bad GERD and you're on a acid reflux medication, or you've had an ulcer in the past. Those types of reasons would be reasons to be cautious about taking a baby aspirin every day. And so I would encourage those individuals who had a bleeding disorder or an ulcerative disease to ask your doc or your provider before you start something like that. But for everybody else in that group, I think the risk is minimal and there's potential benefit.
So Dr. Gupta, I know that you have to run because you have another engagement, and I just want to say thank you for all that you're doing to get out the word to the public and advocates. We really appreciate your time today, and we'll go ahead and make sure to post those links also to our website when we broadcast this event. So thank you so much. I know you got to scoot, and we'll continue to take questions that Dale can answer. So thanks. Hope to see you again, Dr.
Thank you,
Gupta.
Dr. Gupta.
Thanks.
Thank you, everybody.
Yeah.
Bye,
Great.
everybody. Stay safe.
Bye.
And so nice of you to spend your time, precious time with us.
No,
Very
likewise.
grateful.
Thank you so much.
So other questions for
Can I
Dale before we
revisit the
sign
vitamin
off?
D for just a second?
Yeah.
I think that if you know you have low vitamin D, you should be taking it for lots of other reasons, cardiovascular health and bone mineralization as well. So what you do want to be careful you don't overdose. You can actually overdose with mega doses. You don't need that. It's 1,000 to 2,000 units per day, international units per day. So if you're low and you know you're low, and primary care has already checked it, or you have them check it, it's a good idea to supplement. We, none of us, even in sunny climates, get enough vitamin D without putting ourselves at risk for skin cancer. So you can be, living in Florida and out in the sun all the time and still have a low D level. So just separate from the whole COVID thing, what the data that we did see was an association with existing low levels and more severe disease. And so if you don't have a low level, maybe you're protecting yourself that way. So I did want to add that.
That's great. And
Yeah.
several people have been asking, since there have been so many links being thrown around, we'll go ahead and compile them and we'll post them, as we often do, in an attachment when we post the recording. So, and Anne, did you want to pop in here? I see you're coming up.
I just wanted to say thank you. And, again, he is just like the rock star for me on CNN and what he's doing and how he's educating, really trying to educate the public. But your point as to what can we do as advocates, I don't know if he really knew who we were, what we do. But besides that, what can we do and how are we going to do it tomorrow or today? Because there is so much misinformation out there for people in our country, and I'm sure the world. I don't know what's happening in other parts of the world because I'm here in Fort Lauderdale, Florida, but we can't even figure out how to get the vaccine appointments done here.
Right.
And then yesterday my husband went to buy a truck and the guy he called us and said, you have to come later because I'm going to get my vaccine. We got to see him. He never got his vaccine. It was a 4-hour wait. He had to come to work. So he left. Now that is just wrong.
Yeah.
I mean, really, in the United States,
Well, I think I do, and I appreciate those comments. And I think I think one of the things that we as an organization and community can do is perhaps even gather some very simple messaging and graphics to all get on the same page as to promote the very simple messaging that Dr. Gupta suggested. And Dale, it looks like you want to jump in here too.
Yeah, I was just going to let people know that it's the vaccine rollout is a mess. We know that. It's super state dependent and how committed the state was to do it according to a format. And even in Washington State, where everybody was really proactive, Department of Health, and there's a very coordinated effort, we have not received enough vaccine. We had people scheduling, some sites were scheduling it way in advance, and some were not. And so there are places that are rolling out appointments and vaccines in in tiny pockets, and other big places that are not getting, that have proven rapid vaccine administration are not getting their doses. So it's still irregular. And I think the message has to be, go in the phase finder of your state, get signed up. They will tell you where you can schedule, and just sign up for the first available appointment. And so far, we have administered in the United States over 40 million doses of vaccine. That sounds like a lot, but we have 331 million people in the United States. So it's about 9% of the population. And fortunately, most of it has gone to the highest risk, the communal living folks. So those might be disabled, that might be the elderly, group homes for other reasons, and the healthcare workers, and starting expansion into other essential workers, as well as over 65 years old in most states. You're kind of stuck with what your state is doing. So I would make a lot of loud noise. I have an example in one state that providing some information about congregate living for disabled kids and young adults and older adults really helped push the community's pressure on that state to get those people vaccinated right away. And that's an advocacy that you can do, I was able to do with my friend who lived in that state across the country. So the advocacy groups, every one of you guys that's an advocate, either professional or for your own family or whatever, reach out to the folks that you know and send that common message. Any vaccine you have access to, get it. And most of the states that I'm aware of, and this was government kind of suggested, was if you've had COVID and it's been, excuse me, and it's been 2 months, then go ahead and get vaccinated if you're in the category that needs it. So don't hold off. These vaccines actually probably have lower rates of, excuse me, I'm going to turn off the video and keep talking, probably have lower rates actually of anaphylaxis than most of the other medications or vaccinations we are used to. And the other thing I want to really highlight is that we will have a vaccine expert next month to talk about the variants and some of the other things. But even in our state, what I heard is that with these 40 million vaccinations starting in December across the country, we will soon have data out of the VSAFE program that hopefully you sign up for when you get your vaccine, for who really is having serious side effects, not necessarily anaphylaxis, but out of 14,000 vaccinations in the Swedish system, I think we saw like less than a handful of anaphylactic reactions. So it's actually way lower than, typically you would quote 0.5% or something along that line, 1% max of an anaphylactic reaction to an antibiotic, for instance. So these are quite safe. And the other point I want to make just before because we're right on the hour, is yes, I know one of the questions was with the variants, do we need to do more protective equipment? But actually, even if you get vaccinated, you need to wear your mask, wear it properly, make sure you don't have gaps. Do not wear a mask with a filter. It'll protect you, but if you happen to carry the virus, you will infect everyone around you because the filter will blow out anything that you're breathing out. If you must wear a filter, wear a cloth mask over top of it. So there are these N95s that you can pick up at the hardware store or whatever that have valves in them. Make sure that you cover that if that's what you must do to be comfortable. But yes, hand washing, physical distancing, masking is going to go on for a long time, and that's how we protect ourselves, but we also protect others from if we happen to be carrying the vaccine and could spread it, but are not symptomatic.
Thank you so much, Dale, for continuing to, really help us understand what's happening with COVID. And I do want to just put in a plug for next month, March 8th, same time, same place. We will have world-renowned virologist Larry Corey, who will be talking about the vaccine and variants, the virology. So we'll be able to dig into that. You can already sign up for that session. We are applying for BCPA CEs, just like this session. And if you do have questions about that, you'll be getting a link after this session if you did sign up for CEs. And so that will be qualified. And if you ever have any questions, just message us at info@healthadvocatex.org, and we will talk to you hopefully and see you next month. Thanks so much. Bye, everybody.